Welcome to the CoROM Conversations for July 2025. We have Bill Vasios and Rhod Jordan as co-presenters. Bill, you can have a quick intro to yourself.
Hello, Bill Vasios. I'm a former 18 Delta PA and current PhD candidate doing a medical simulation fellowship.
Rhod?
Rhod Jordan, 30-year paramedic in all sorts of environments, and very happy to be part of the college for all these years.
Yeah, good deal. So this is very much an open mic night. You are all part of the extended family of CoROM, so do please answer or answer questions as well. It'd be great. But ask questions as we see fit. So this week, this month, we're going through the H in March, D in disability for the CoROM CABC. And as always, I'm going to show you where we're getting our data. So this is a list of CPGs, and I've broken them down into March pause, and we are basing our research off of this as well as other research. We'll quote this. So if you do want to download that spreadsheet that has all of those links, you can do so now. And so we have on the left our civilian CABCD system, and this is the new 3rd edition of the field guide that we're putting together. And on the right is the March pause. And it's medicine is medicine. It's just the way that an algorithm that we use. So this month we're doing D, disability, or H, in our March algorithm, which is hypothermia, hyperthermia, and head injuries. We're using the guidelines that can be found on the DHI website. And in that website, they have TCCC skill sets by responder level. We're looking at CP. CP is combat paramedic level. A lot of you guys are paramedics. And we'll kind of touch on the other levels, but that's basically first aid level, and it's a bit below us. So looking at our CABC, we're going to focus on D, disability. And I've combined the top white section from the TCCC guidelines, and the green section on the bottom is from our CoROM. And let's talk about TCCC first. So gentlemen, for head and TBI, what are we looking for?
Well, head and TBI, you're looking at the primary injury that you can't do anything about. All of the treatment that you initiate as part of March or a secondary or whatever system that you're using to do is to prevent the exacerbation and the progression of the secondary injury, which is the swelling and the byproducts of all of the damage during the primary injury. You can't uncrush the head. You can't unpenetrate the skull. So basically you're doing everything to manage the secondary or consequences of that primary injury. And so that guides your therapy.
So in initial assessment, what are we doing for our TBI head injury?
Well, isolated from any other injuries, you're going to do an initial stabilization, making sure through that the airway's good, there isn't any significant bleeding. You're going to follow the March algorithm till you get to the assessment. When you do your assessment, the easiest assessment you can do for a head injury is talk to your patient. If they're able to talk, if they're conscious, talk to them. That will give you the best indication to where they are mentally. If you've ever had conversation with somebody that's sober, and then you have a conversation with them after a few pints, you see the effects of a head injury. Essentially, they can be altered in response. They can be delayed. They can be inappropriate. They can do all of those things that'll eventually you'll try to categorize in total during your Glasgow Coma scale, but that's later. Your initial assessment is going to be the AVPU scale, which are they alert? Do they respond to verbal? Are they only responsive to pain, or are they unresponsive at all? That's going to be your first thing. These are pretty straightforward. A lot of this will take place the minute you approach the patient or as you're moving up on the patient, or if they are moving to you. You're looking at their gait. I know when I work in the ER, when I watch a patient walk from the waiting room to their room, and depending on what their chief complaint is, I watch how they walk. I can see how they're moving, how they're communicating with the nurse that's walking them down there. I mean, all of those things are tidbits and clues. And so you need to be able to take it in its totality of your assessment. How are they moving as you walk up to them? How are they responding to the pain? Are they localizing the injury by putting their hands on their heads or put on any other injuries? Like all of that stuff is part of your initial assessment when you walk up on the patient, and then you become focused based on what you see. And the options are basically unlimited, but kind of go to the obvious things first. Like, what do you see?
Yeah, good. On the next slide, we'll start deep diving into this. But for hypothermia, hyperthermia, Rhod, what's the big take-home message for that?
Well, I'm like on both of those. So, I mean, Bill's absolutely nailed it. I mean, as first responders, it's going to be airway, it's going to be oxygenation. But other things that we can really do to help with the thermoregulation of the body that are going to assist with all those processes. So whether it's cold prevention or bringing down heat, then that's all got to come into it as well. And for me, that hyper and hypo prevention comes right at the top end of the March algorithm when we're still at big C, let alone moving down into the PFC side of it.
That's a good point. In parts of the world, it's -40, and is that a big C problem? Even though is that an M problem in dealing with the casualty?
It's absolutely an M problem. Whether you're in -40 or +40, or you're in a Northern European environment, there's some very good evidence and research to suggest that even urban ambulance services with all our Gucci kit, we're not looking after that side of the patient, and that has a massively detrimental effect on long-term outcome.
Good.
Quick question. Yep. Two questions, actually. So one thing I have found a big struggle in determining whether or not I'm going to address hypothermia or hyperthermia is just being able to get a temperature, because I don't know about you guys, but the reliability of a thermometer is about the same as my finger. And sometimes it seems really just, obvious hyperthermia is not difficult to have. And someone who's like, you've got a lot of historical evidence around it, then you can address the hypothermia. But those like borderline patients, is there any detriment in just warming them up anyway?
Tanguy, perfect. Don't go for the instrument. Just take it as a consideration when you first approach your patient. So I think the point I keep trying to make is think about hypo or hyperthermia alleviation right from the start of your approach. Don't worry about what thermometer you're shoving in whatever hole. I hate to use the word, and Bill's going to talk over me in a minute, I know, but it's that holistic patient approach. And I don't like that H word, but it is just have it within your head all the way through.
It's kind of a gravity response. If you are, it's just there. So if you are at a -40 or a +40 environment, you kind of know where you are. If you're cold just standing there, your patient is colder. If you're hot just standing there, your patient is going to be, the effect. So you're going to make some assumptions on how you feel, and just know that it's probably exacerbated in the patient's perspective. So it's nice to have an exact number, but you have to initiate therapy based on the environment you're in. And if you're in a cold weather environment, you got to warm them up. And if they're in a hot weather environment and they're overheating, you got to cool them down. And so there's general principles. And at some point you're going to be asked to document a number. Part of that documentation is saying this is after the fact, or I had an extra person with a thermometer and they did this, this measurement at this location, and we can all infer the accuracy based on where you took the location, right? If they're mouth breathing, oral's not going to be that accurate. If it's underarm, those things are never accurate. If you are able to get a rectal, realize that that's not a free test. You have to expose the patient to get in there and do that, and at what cost. So even though you'd like to have a hard number to write down, that's paperwork, man. You got to deal with your patient. And so your gut instinct is to be just go ahead and initiate the treatment. And then at one point when it's most convenient and less detrimental to your patient, go ahead and document it.
I love the perspective that you guys have on it just being like an intuition situation. I think the situations in which it gets a bit more difficult are, you've got a relatively controlled situation, and telling if someone's febrile versus just below febrile is, in my opinion, not easy, right? I touch a lot of people, and you'll think, wow, this person's hot, and you got a temperature, and it's completely off. And I love the fact that you brought up the rapid respirations, because even if they're just septic, or they've got some type of DKA situation, it's amazing how much that oral temperature can be completely off. And my sort of question with this is, are we thinking of hypothermia prevention as being a little bit like hyperglycemia, hypoglycemia? Isn't, if we're going to do anything, might as well just warm them a little bit if we're in that in-between situation, or are we just going to leave them alone and possibly risk hypothermia? What would you rather go towards?
I think I've already answered it. Probably not terribly well, Tank Aebhric. Always have it as the consideration. It's always part of my treatment algorithm. I understand where you're coming from as a very, I don't mean it disparagingly, but street paramedicine and having to do that, I must have a number on the paper. So going back to what Bill's saying, yes, further down the line, once we've dealt with all the immediacies, by all means, whichever methodology you've got for gaining a reasonably accurate temperature, go for it. But manage hypo and hyper all the way through, just as part of your basic patient handling.
Awesome. So just keeping it in the front of your mind. I'm sorry. Last question. The mini mental status assessment, from what I'm understanding, is it's basically what we're doing right there. There's really no difference. And have you guys found any use in it, or is this just another way of reframing or rewording what we're doing actively?
I think taking a mini mental depends on the situation. So if you're at point of injury, if you're right there when it happens, then you're going to do your march, and you're going to go through this, and you're going to have conversations, and you're going to gauge their responses and how appropriate and accurate they are. And that all goes into your initial assessment that, your field, this patient is not doing very well, or they're doing okay. Their response to pain and their response to everything is appropriate. So then it maybe isn't as severe a TBI injury. I think where you get into the mini mental status is when you're in a very clinical situation or a very controlled environment, and you're well past your secondary exam where you're trying to assess where are they at. Ideally, most of the military folks and most of the people that are intentionally going out there, they may have a baseline mental assessment beforehand. And if you know the person beforehand, incorporate that information into your questions to them. Like, hey, you ready to go home and see your dog, kind of thing. If you know he's got a pet, or you got a kid, or, whatever you were talking about yesterday, bring that up and see if they're still, responding appropriately to that. That's one way to do it. If it's a stranger, introduce yourself, and then later say, hey, do you remember my name? Those are ways to kind of, and it's creative. Go with your personality and your techniques. If you're a big talker, you'll figure out something to say. If you're a quiet person, you'll figure out something to say, because it'll be meaningful. And you'll say, hey, do you remember this? Hey, I'm going to tell you, remember this color, blue. Later on, do you remember this color? You can keep it really simple. You can even go, hey, what color shirt am I wearing? And if they respond appropriately, then, okay, do you say, still remember what color is my shirt? And so you're gauging, trending. Are they getting better? Or are they getting worse? Right. So I wouldn't hang on a mini mental status, until I'm well into the secondary, well into a controlled environment.
Good. All right. This So these next slides are deep dives. So we have hypothermia, hyperthermia, TBI, and the two levels of TBI. So if you look here, so let me orientate this before the lads start deep diving. This is from the CPGs. So the hypothermia CPG has ruck, truck, and house. We all know that. And it has that broken down into CLS. Combat Lifesaver is a 5-day course, first aid course. CMC is a combat medic. They're an EMT-ish level about an EMT. So we're going to talk about these because as paramedics, as combat paramedic level and higher, if we have docs on board today, we are going to do everything in CLS and CMC, and we're going to do CPP. But for hypothermia, if you see in the top left, the advanced practice is exactly the same as CMC. So let's talk about hypothermia. We probably already covered a lot of this, but this is the CPG for hypothermia, and we're going to focus on the blue, which is our level, which is the advanced level treatment. So any questions or comments?
Hey, Rhod, anything stick out to you as far as where people mess up the most? Like where's the common mistakes? If you just kind of use this as a reference and you jump into doing something, where do people screw it up the most?
I think the most common mistake, mate. Sorry, I've flicked across to the big screen, so my camera's here. Is that very basic right at the start, and it's that old adage of the 3 under 1 over. And it literally is, because, people on this talk will be fed up of hearing me saying it, but we rock up on scene and we're really good at throwing something over the top of people and not insulating from the bottom. And if you don't get that base level right, every pun intended, there's very little point in moving on to the rest of it. We're going to go for all the Gucci stuff, and we've missed Billy Basic over again. So 3 under, 1 over, wind protection. Just get the simple things right from the word go, and everything else should follow quite nicely.
No, I like that. I see a lot of that in the training, where people will cover the patient and won't prevent, put a barrier or a layer underneath them, or sufficient layers.
We've already alluded to one point already. We want to get temperature monitoring on stuff on people because we've got that kit in our bags potentially, or on the back of the truck. Well, do the simple things, do the basic things, which is, that insulation from the ground, from the air, the wind protection, precipitation, and then worry about getting your dots on and your probes in different orifices later down the line.
That's kind of like a truck phase then, isn't it? Or a house phase.
Yeah.
So we can clinically look at the level of shivering they have to assess what we need to assess. And here's the other thing. The treatment's exactly the same. We put them in a burrito wrap and we put a fluffy stuff all around them. It doesn't matter if they're 2 degrees low or 3 degrees low. It doesn't change our clinical, does it?
Not at all. Not at all.
One of the things I see a lot in the training environment is when they do burrito them up and wrap them, they have the wrap on one side of the patient as opposed to centered on the top. And so whenever they access, say they have it folded and the opening is on the right side of the patient, if they need to do something on the left side, like, do a fast exam or vice versa, they're exposing the full thorax and leg, and that they're losing all that heat that's been built up, that's generated and minimally by the patient, but whatever external warming device you have in there, whatever's trapped, that's gone because they open it up. And that's one of those things. Any techniques that you can recommend, I just put the opening at the top center so that if I have to access one side, I can fold the top back down over and cover as much of the patient and access the left side versus the right side. But any other techniques that you can think of?
Yeah, so there's some that I know Abe's on it, and we've been teaching it at the college and elsewhere for some time. Is, if you've got your BP cuff here, have it taped up and it coming out the arm with the steth underneath. Have your thermometer probe underneath the axilla with the actual reader outside the burrito, so you're not having to expose to get those basic readings.
Oh, that's good.
That's one of many reasons we use cling film or saran wrap for everything, because that saran wrap can wrap that ECG 3 lead on top of the BP cuff, so you can access that without having to get your casualty unwrapped. So Bill, you asked what can we do to minimize that? The wilderness medicine has so much to give us, and we're not embracing it. So the bothy shelter. Anyone here doesn't know what a bothy shelter is? So yeah, a bothy shelter is something that I learned in wilderness medicine on this side of the pond, and it's this tarp that you pull over yourself and the casualty, and it's used for hypothermia. So basically, it was created for mountain leaders when they have a group out and there's 16 of them and everyone is shivering. This huge tarp, they put everyone over it, and literally 30 seconds, I'm out because it's too warm. So why are we not using that over a casualty? So that way there's no wind, your body heat is kind of warming so I found an 8-person bothy shelter is perfect size for me and a casualty.
No, that's interesting. That's great. It's a great concept.
Well, I've been around for donkey's years. I mean, not that I'm old, but the KISU, as it was, the Carrymore Instructors Survival Unit, was basically, it was derived from an old piece of parachute. You had it in a little stuff sack in the bottom of your mountain leader bag. I'm going back to the 80s now, but you basically get everybody stood around it. You grab an edge each, you fluff it up in the air. You all get under, tuck it under you. You're out the environment. Got complete wind cover, and it heats up, as Aebric's just saying, in seconds. It's fantastic and cheap as chips.
Well, I remember doing map checks when I was in Rangers in the mid 80s. Everything had to be covered for your noise and light discipline. Same thing when you're turning even the red lens, you're undercover and all that stuff. So the same concept. And yeah, it would get incredibly hot underneath there while we're doing it. So yeah, no, that's a great concept. Hadn't really ready for bringing it up.
Any comments from the attendees on any of these concepts so far?
Sean, you had a hand up a minute ago and you've popped it down again.
Oh no, I was just raising my hand in response to Aebhric. But thank you for asking.
Fair enough. So, good. Any other comments before we move on from hypothermia?
Somebody dropped a link to shelters in Alpine Rescue. Can they create a comfortable zone at the deployment site in the chat? That's an interesting article.
Yeah, it's
Nice.
a very good one. Thank you, Tango, because that's a very recent one, if I remember rightly.
24. Yep.
Yeah.
Cool. Okay. Hyperthermia.
Right. Again, I would massively important. With all your coagulation stuff, etc., needing to go on. From my perspective and experience, go from a very simplistic start point. Look for, if possible, remove your casualty 2 shades. Think about stripping down, misting and fanning for evaporation, cool packs under axilla, groin, back and neck, forehead. All that good simple stuff works an absolute treat. So before we start getting too carried away with, I'm technologically challenged, so I do stick to the simple stuff. But go for those basic field approaches first, and that doesn't matter whether it's wilderness, austere, or urban medicine.
So, Rhod, when you work in Iraq and Kurdistan border a lot, and you had a picture of a schmog that you used to top cover. Explain that one.
So basically, one of these badges, and just get people to hold it out over the top, get a bit of shade on. I mean, you can just by putting a bit of shade on. Even I mean, I was there 10 days ago. We were in high 40s. You put a bit of shade up, you're going to drop that ambient temperature over your casualty by 2 degrees centigrade. For those of us that use proper measurements. And then you then start removing the outer clothing, etc., start to do the misting and the fanning, and you're doing a very gradual, very controlled reduction of core body temperature, which is what you want. And I would emphasize that, folks. You really do that. You want a gradual decrease, it's not an ice bath by any stretch of the imagination.
Go ahead, William.
Rhod, you just said there that it's not an ice bath. However, given how in a hypothermic condition, how hot your patient is, if they are, they're very hot, whatever it may be, 38 degrees, 40 degrees, so on and so forth. A lot of the literature that I've read or seen has said that you need to rapidly cool these individuals, and if you do have access to an ice bath and so on and so forth, which you do see at these endurance events and all of that good stuff, then you should use it. So I was just wanting to bring that one up because
no, it's a reasonable one. It's a good excuse me, William, it's a good one to bring up. How controlled is that environment though that you're putting them into that ice bath at an endurance event? What other equipment have you got from a ICU type perspective to look after them? There was some very good research from, I think it was USMC, Marine Corps, some years ago now, and that rapid, from a very high heat, 40 plus centigrade core body, to plunging them into the ice baths was quite detrimental. So you do want to bring it down, but it needs to be controlled environment.
Okay, thanks. It's just I hope you appreciate that there are other people out there that are discussing.
I fully get that, and I think where a lot of these come from needs to be around what's your clinical setting when you're doing that cooling.
Thank you.
So there's the science shows that putting someone in an ice bath is the fastest way to do this. But how many of us work in that environment? And then the most important thing, which Rhod already said, do you have an austere ICU surrounding this guy? Because overshoot is a risk, as well as cardiac issues. You need to have an austere ICU, which I think everyone should have. We have the ability. Everyone should have the equipment to do that. If you do, then you can think of rapid ice bath. But in our environment, mist and fan is going to be available to everyone everywhere, and it's not resource heavy. The ice bath, to my understanding of the science behind that, it is pretty resource heavy. Am I wrong?
Aebhric, not at all. It's just I thought I'd bring it up. I'm currently in an environment that's about 40 degrees, and I work with a bunch of people that they do have access when we're out on the ground. They do carry ice and all of that good stuff. However, my go-to is, as you said there, a water, one of those funny little spray things that you can attach to any water bottle. Fan, shade, jobs are good. And it's just I thought I'd just bring it up. That's all. I hear you completely.
I would definitely want a high-grade rectal thermometer if I'm going to do an ice bath on someone. Alfredo?
Hello, I just would like to add something else. Doing the masters in austere critical care, Dr. De Mello mentioned something that I was not aware, and then I went out and researched that in Saudi Arabia during the Hajj, instead of using ice packs in the groins or axilas and so forth, instead they put it on hands and feet, palms of hands and feet, and apparently it works much better than the traditional places, forehead and so forth. I just want to say this because initially Dr. Demel raised that, and because I was working in Saudi Arabia and actually I was covering a Hajj per se, because I'm not a Muslim, I cannot go in there, but I got in contact, I got the document, and they actually said the guideline said it was the most efficient way to drop the temperature, apart from spraying water and so forth. It was also using ice. Just to drop this up.
That's all right. I'm busy writing that down, Alfredo, because I need to follow up on that because that sounds intriguing, mate. Thank you.
I think with any severe temperature swing for any patient, if you're rapidly rewarming, or in this case, rapidly cooling somebody that's in a hyperthermic situation, you realize if that internal thermal regulatory method is management is damaged, you can overshoot your target. I just pulled an article up. I can drop a link in the chat about severe accidental hypothermia with rapid cooling. And so I think I like the idea of the hands and the feet. It could maximize your limited supplies, right? Because you're only putting them in certain locations for higher yield. I like that idea. But I'll drop the link in this for this article in the chat.
Yeah, go ahead.
Just to kind of backtrack a bit with the hypothermia. Now, hypothermia. I believe, as Bill mentioned there, with that rapid rewarming and all of that type of thing, you get rebound because of the perfusion and all of that type of thing. There's some complicated free radicals or whatever it may be, but in essence, with the rapid rewarming, you're now getting perfusion to those peripheries, and it's not great for you. That's, I don't know if you can add to that.
It's also painful. Rapidly warming extremities will increase circulation. It's just like having your hands or your extremities being numb from going to sleep from pressure or something like that, and they get reperfusion. That can be incredibly painful as well.
Thank you.
Yeah, Andre?
I just wanted to add to what Will said. Like it was in my preparation for Valdem's paramedic certificate, and yeah, they were saying basically when you start rewarming those peripheries, when the blood starts circulating to those areas which were exposed to the cold. So basically, like you cooling that warm centrally circulating blood and bringing it back to the core, so that may aggravate further. So yeah, and what I actually can add also to those to that concept of cooling, as Alfredo said, hands and feet. That's also now, I think, and the latest recommendation of in Wilderness Medical Society guidelines. Apparently, this glabrous skin, as they call it, which is hairless skin, cooling in these areas provides quite effective cooling to the whole core. So just some touch on that.
It almost sounds like a reperfusion injury comparable to crush, and that may be the enzyme that you're talking about, William, as far as getting back in there. So I would definitely look at making sure the kidneys are perfusing. There's urine output. if one of your techniques to rapidly cool or warm is to change the temperature of IV fluid, that might be another way to control that. You're kind of making sure the kidneys are working and you're using that fluid to internally warm or cool a patient. I was confessing to Rhod and Aebhric beforehand, like most of my severe temperature patients in the past have all been, I've been surviving and reacting in treating them. I don't have a great deal of experience in that area. It's mostly mental exercises. Like, all right, what would happen if somebody went down in this environment, minus or plus temperature centigrade. Rhod, I heard Sean Keenan talk about centigrade and Fahrenheit. He goes, there's those in the world that use centigrade, and then there's the rest of us that have been to the moon. So you can only throw so much shade.
Allegedly.
Okay, that's a whole different podcast. Perfect. Never take yourself too seriously.
Try not to, Mucker.
Absolutely. Yeah. So no, I think a lot of this has been flying by the seat of the pants and understanding the structure of the injury and the structure of the situation versus just memorizing a process. And that was a discussion that Aebhric and Rhod and I had beforehand. It's like, how do we target the information to you guys? And we're all smart enough in this chat to read this information and process it. The question is, how do we apply it in these weird, extreme situations? And in that regard, you have to think your way through it. Well, what doesn't exactly appear on, slide 15, then, are we still able to function? One of the things that I look at all of this is, where does the CPG in the guidelines recommend some technology, whether it's a digital or a battery powered warmer, cooler device of monitoring, whatever it is, how do we function when that doesn't work, when the batteries run out, when the device fails, when the cord gets crimped? So I think in any process that we look at, the ruck, truck, house, that progression of good, better, best. If our best is to have this digital or electronic or technology driven monitoring device, resuscitation device, assistant, whatever it is, how do we function when that doesn't work? And that's a mental exercise that we have to go through all the time, no matter what, every situation. And that's during the downtime. And when we're deployed, we're incredibly busy, but we're also have a lot of time on our hands. And this is one of those mental exercises that we should all go through.
Yeah. So when I look at hypo and hyperthermia, I'm a knuckle dragger at heart. So I want to look at a quick assessment and non-clinical or clinical ways to see something as I'm approaching them, to get an assessment of where they are in the spectrum. So I follow the WMS suggestions, which are three things: 3 types of sweating and 3 types of shivering. So for the hyperthermia, we're talking about that. They're going to be sweating, violently sweating, or not sweating. And so as I look at a casualty, if they're still violently sweating, awesome. I'm going to mist and fan and hydrate the living hell out of that with normal saline orally, and because they're compensating. But as soon as they stop sweating, that's the problem. And then shivering is the same way. They're shivering, they're violent shivering, or they're not shivering. And so as you approach your casualty, before you even touch them, you should be able to get a rough idea of how they're compensating.
And you would gauge any changes in that. Where are they trending?
Yeah, because we always want that baseline, that trend over time, don't we?
Absolutely. That you're getting a snapshot. Yeah. If you're looking at if they're shaking and shivering when you get there, are they shaking and shivering 10 minutes after you get there? You do an intervention, you reassess. Does it change? Does it improve? Does it get worse? All of those things. Sometimes it may appear that it's getting worse, but if a hypothermic patient and you're warming, their symptoms are going to get worse. Their complaints are going to get worse. They're going to actively shiver as they're getting rewarmed versus when they were not, right? Their pain level, which was controlled initially when they were frozen, is actually going to elevate because of that reperfusion stuff. So I think all of that, understanding the underlying structure of the scenario versus just following an algorithm, I think it's going to make us next level providers from where we currently are, I think.
I love the way you worded that, Aebhric. I think the idea of being able to use our different continuums of treatment in terms of hyperthermia and hypothermia, including, something that is often, I think, either contentious or like disputed against, is the idea of using physical activity as a warming method for hypothermic patients. And I mean, like coming across your patient and saying, hey, this person's just shivering a little bit. They're still able to move, and going, hey, let's do a couple jumping jacks, versus you get to them, they're not shivering anymore, they're mumbling, then maybe we'll progress to maybe the alternate level of care. I love that. Thank you so much. That was great.
When I was decades ago, when I was a wilderness psychologist, and we would have these Hoods in the Woods program, these kids would be in the middle of nowhere, and we were dealing with their issues very successfully. When they're cold, I would say, hey, can you help me out? Can you get this pile of cut wood and carry it over there? And they're grumbling like, I don't want to, and they'll carry the wood over there. And then I'll say, great, can you carry that pile of wood back to where it was? And then just back and forth until they finally get warm enough, until they finally say, hey, wait a minute, why am I doing this? And now I know their mental status is back to keeping them warm. So Tange, excellent of let them, get them to work. As long as they have glucose, yeah, let them warm themselves. All right. We have 20 minutes left. Shall we do a deep dive into TBI? So this is the CMC house, truck, and ruck continuum.
So I think a lot of this we've kind of addressed at different times. So how do you do your initial assessment on your patient? Like I said, I'm a big fan of talking to your patient. If they're awake and can respond, get some kind of response from them and gauge that over time. Does it improve? Does it deteriorate? Does it sustain? Those are pretty common. When you get into your specifics and dig deep into your physical exam, you're looking at pupils, you're looking at, cranial nerves, whatever your assessment is, figuring out the source of the injury. Is it a penetrating injury? Is it a crush injury? Is it a hypo or hyperthermic injury, and that's altering their mental status? All of those things, you take that into consideration. And if you have specific questions, we'll address them. But I'm just going to say generically, you're going to do the appropriate assessment based on the initial part. Some of your goals, you'll notice that the TBI, blood pressure, and oxygen saturation are slightly different than just regular trauma. Why is that so? You initially, for hypothermic hypovolemic management, you want the systolic to be greater than 100. With the head, they want that to be more. And do we understand why? Normal vasculature to brain ratio in your head is about 80-20. So it's about 80% brain and 20% vascular space in your ventricles. So normal circulation will function in there. As the brain swells from whatever primary injury, getting into that secondary damage that's going to cause, you want to increase the blood pressure to get by that swelling. So your brain can compensate. If you're a visual person, normal's 80-20 ratio. Your brain can compensate up until it gets to a 90-10. So that means that the brain is swelling an additional 10% at the expense of the vascular area. So it's the same thing as kinking off a garden hose, right? And so you need greater pressure to get circulation through to perfuse the brain. And so there are some articles that say your systolic blood pressure in a head injury, a severe head injury, it needs to be greater than 110 even, right? But in a polytrauma patient that you're treating hypovolemia and a head injury, that's a very complex patient. It's not a series of simple tasks or even a series. It's a series of complicated tasks which make them complex, make your patient complex. And so your systolic blood pressure needs to be inherently higher to overcome that resistance from the swelling of the brain tissue. Does anybody have any questions about that?
William?
In the interest of making this a little bit more difficult, let's throw in a non-compressible injury where where usually you aim for hypotensive resuscitation. However,
Mhm.
this poor bugger has also got a head injury. So now, in this scenario, if we do increase that pressure to 110, then we're likely to pop that clot and for the primary catastrophic bleed to start hemorrhaging again if it hasn't stopped already. So I guess my question to you is, which one are we going to be going for here? 110?
Yeah. So no, no, that is a great question, and that's why we get paid what we get paid, right? As good or as little as that is, we're dealing with the difficult. In this, you're describing a scenario where you have to choose the least horrible option. It's not the right or the wrong, it's the least horrible. And so when I have to give somebody significant reperfusion, I'm replacing a lot of blood. Our tendency in a hypovolemic patient is to rush it in using some type of an infuser, rapid infuser, or you're doing compression on the bag manually with you squeezing the blood bag to try and get the blood in there. I think once you get to, and this is a technique and wide open for discussion. When you get to a point where you're at a systolic of 100, right? And you're worried about breaking clots, at that point, just hang the blood to gravity. Don't try to infuse it in. Don't force it in, because there's an inherent resistance to the vasculature when you're putting blood in, and it will not allow the blood in to flow to gravity to break those clots. If you've done your TXA and your calcium and all those other things that you do per the fresh whole blood protocols. Does that make sense?
Yeah, that does make sense. But in quite a few, well, certainly with West Australia, St. John's Ambulance, their CPGs state that with non-compressible injuries, they are targeting a systolic, I think it is of 60 or 65. Don't quote me on that, but it's certainly not higher than 65. So that is a long way from a systolic of 100.
I would clarify, is that a MAP of 65 or a systolic blood pressure of 65? Because a MAP of 65 is what's acceptable. Yeah, I know.
Sorry, I think it was a systolic. I cancel a MAP.
Okay. Yeah. And you know what goes into the MAP, right? If you can do the quick math, right? It's 2 times the diastolic plus the systolic, right? Is that what it is?
Yep.
Right, divided by 3.
I do it by you've got your pulse pressure, divide that by 3, and then add a third to your diastolic.
So if you just take a blood pressure of 80 over 50, right? You get a blood pressure and it's 80 over 50. What is the MAP for that? Quick math, right? So 50 times
60.
2 plus 80 is 180, divided by 3 is 60, right? So if you get a systolic and if you get a blood pressure that's 80 over 50, your MAP is roughly 60, right? And that's only a surrogate. MAP is a surrogate for how that's going. It's a squint your head, turn your eyes, kind of, figure it out. You're kind of gauging what it is. You're not doing an actual measurement. It's a surrogate for figuring that out. So you can have a pretty low systolic blood pressure, and that's your permissive hypotensive. That means that you don't have an immediate problem. You have a delayed future problem, right? Because if you underperfuse the kidneys, if you underperfuse the heart, if you underperfuse the brain, then you're going to have secondary injury down the road. So the whole reason is to make them survive March, get into the secondary, and then look at, life changes, and their quality of life later on in secondary, acute kidney injuries and cerebral hypoperfusion, all of those complications. I think you get down into, this could be a triage issue. If you have limited supplies of fresh whole blood and you have multiple patients, you're going to have to, if you have a head injury patient and a hypovolemic patient and a separate hypovolemic patient, you have to decide where that blood's going to best utilize. And so you have to look at all of that. I would shamelessly put a plug in for the advisor system or any teleconsultation, right? Teleconsultation is you calling and asking for help on how to manage your patient. I think reach out and talk and ask questions and get a secondary opinion. Get somebody that's not under the same stresses that you're dealing with right there. But these are difficult. This is not a right or wrong question. This is the least worst option of my situation.
Thanks, Bill.
Yeah. No, great question. Because honestly, that's where the learning takes place, because we can read this and we can have a good idea of what's going on, but we have to understand the physiology behind it. And how do we think through those situations? That's the medical decision making that we all need, no matter where you are now, you could be better than understanding that. Yeah, it's covered in teleconsultation. Aebhric, if you can go to the TB Glasgow Coma Scale. So when you're doing your initial assessment on a patient, and this will kind of take us right up to the end, I think, you're doing are they alert, responding to verbal, responding to pain, or are they unresponsive? At some point during your care, you're going to have to do a Glasgow Coma Scale. And I will confess, I have memorized and forgotten this scale countless times. Right before I go into the ICU or doing something, I'll refresh on it, and then, you have patients and you'll remember it. One of the best references that I've seen that explains this very well, and I will take and put this in the chat, the source down here from ICU Advantage. Let me pull that up. And drop that in the chat. Okay. So a good way to memorize this, or at least understand it, is everything below the red line is a brainstem function. So I don't think any of us need to spend any time or, sing the nursery rhyme of, if it's, the Glasgow Coma Scale less than 8, you must intubate. There's been a change recently to say you should resuscitate them before you intubate. It really depends on your training, your supplies, your personnel, your status. All of that factors into what do you do. Because intubating somebody or criking them or controlling their airway is not a free procedure. It counts. Once you take somebody's airway, you own it now. You're responsible for them to make sure that they continue to breathe. You're securing it, but you also need to, own it. And that's not free. So a lot of times, depending on what's going on, I will wait as long as I can possibly get away with, because I understand the obligation after I take somebody's airway. And I think we get caught into the mindset of, I got to do a procedure, or I get to do a procedure. And we don't look at what does that procedure cost as far as time, equipment, management, personnel, all of those obligations that come with taking an airway. But how to remember this? What does it count? So if you look at somebody, and specifically for eyes, so in the let's say, give an answer here. If I'm sitting there, if I'm the patient and I got my eyes closed and I'm just in my happy place trying to make the pain go away, and Aebhric walks up to me and goes, "Hey, Bill, if I open my eyes when Aebhric calls my name, do I get a 4 or do I get a 3 in my Glasgow Coma Scale for eyes open?" So let's do it by hands. How many people say that I get a 3? Okay. Here's why that's wrong. And why do I start with this? Because, it's like, why do you rob the bank? That's where the money is. This is the thing. If I'm sitting there and I'm in pain, and my happy place is to close my eyes and not have all this overstimulation, and I just want to be still and quiet to control that pain, my eyes are closed. If Aebhric calls me and I open my eyes when he calls my name, the determining of whether I get 3 points or 4 is, where do my eyes go when I open them? If Aebric's walking up to me and he says, "Hey, Bill," and I open my eyes and I look right at him, I get a 4. I just had my eyes closed. It's kind of like Ranger School saying that I wasn't sleeping. I was just praying, right? I was doing whatever I was doing to not be in pain. So if I open my eyes and I look at the person that called me, that's spontaneous. I just happen to have them closed and I'm focusing on you. But if Aebhric calls my name and I open my eyes and I'm just I got roaming eyes or whatever, and I'm just whatever, and he goes, "Hey, Bill, over here," and I still don't, move my head to him, if it's delayed in really any way, then that would take a point. I'm opening them to verbal, but if I open them and look right at you, I get full credit for that. So why does this matter? Because that's 1 point, and that's really a simple thing. If I don't open my eyes when you call my name, and the only thing that makes me open my eyes is you doing a sternal rub or pinching my finger or doing something painful, then, that's a subcortical or cortical function of the brain, not a brainstem function. If I only open to pain, then that's a brainstem function for eyes. So that's a very common mistake that people make when they're assessing their Glasgow Coma Scale, right? It's what the eyes do when they open. That's one thing. Anybody have any questions or comments about that? Okay, so verbal response. If I'm asking them, and this is why talking to your patient is so valuable. If they're normal, that's a gauge, right? That's full credit, right? If they're not responding, that's 1 point, right? The rock, or my headphones or my dog gets a 1, right, for no response. The difference really is the difference between being confused and inappropriate. If it's incomprehensible, if I'm mumbling, I'm just moving air, and so that's below the brainstem. That's a brainstem function, not a cortical or subcortical. The difference that you really need to calculate is the answer confusing or inappropriate? I love the video when they show about 2 weeks in hell about the SF selection, where the guy's doing PT and he's altered a little bit, and the guy was like, what's your name? And he's like, hash browns. And so that's an inappropriate answer. He answered, he gave a real word, but it wasn't appropriate for the question. So when you're talking to them, especially when you say, hey, what day is it? If you're not sure, if you've been traveling and you're not sure about what day it is or what date it is or what month it is, that if you're confused, it's like, oh, is it Tuesday or Wednesday? That's a confused answer. Like, it's one of the days. It's probably Tuesday or Wednesday. I'm really not. What time is it? What time zone am I in? There can be some confusion as appropriate. But if I say, what day is it? And you go, June, that's inappropriate. And so you lose your points on that. So full credit is easy, and anything in the brainstem is pretty easy to get. Incomprehensible or no response. What you need to know is what's a confused answer and what's an inappropriate answer, to where they get a 3 or a 4. Does that make sense? Okay. All right. And then motor response. So this is another one that gets confusing. If you're walking up on the patient and they're holding something that's obviously deformed and hurt, like that's where the bullet went in, or that's where their arm broke, or any of those things, and they're obeying your command, and you're saying, hey, here, grab my hand, I'm going to pull you to safety, kind of thing. All of that's perfect. The difference is when you localize the pain or withdraw the pain, it really has to do with where do you test and how do you test. So if your patient is laying in the litter and they're laying on their back, and you do a sternal rub from pain, what's the appropriate response if they're localizing? Right? It would be to reach for your hand and stop you from doing that. That's appropriate. If they're not listening to you, or they're not able to grab your hands and squeeze your fingers, then if they localize, they'll localize to it. But how do they withdraw? If you do a sternal rub and they're laying on a litter, how do they withdraw? Right? So once again, they're going to flex or they're going to localize. So if I just try to swap it away, if I'm just doing a blind sweep to get your hand away from doing a sternal rub, is that localized or is that flexing or withdrawing? So it's a very confused answer. Same thing as if you use the finger. If you pinch the finger and it hurts, right? What's the appropriate answer? If you pinch my left hand, localizing to pain is me reaching over with my right hand and stopping you to do that. So that's confusing. My normal reaction, a natural reaction, is to pull my hand away. So is that localizing to pain or withdrawing? So that can be confusing. And how do you score that, right? So you can do something that gives them the ability to localize or withdraw from the pain. You can do it in the upper arm. You can do it in the elbow. Try not to do it on the extremities, because every normal response will be to pull my hand away, and that's withdrawal, and that could be inappropriate. So whatever you decide to do and how your patient's positioned, really think through. You can do an ear pinch, right? But if you got a spinal injury, then this withdrawal is going to make another injury exacerbated if they've got a C-spine or, some kind of collar in place. So you really should think through how you're going to do your assessment for motor response. You can hold the hand and you can do something in the center, right? And so do they actually grab your hand which would be localizing. Like this is the closest thing. I'm going to grab your hand and stop you from doing whatever you're doing to the center of my hand. That's one way to do it. Obviously excluding any kind of other injury to that limb. Pick a limb that doesn't already have an injury, because that's going to exacerbate pain. If I have a broken arm and it's splinted appropriately, which is covered in the PCC and the PFC guidelines, then my pain is reduced because I'm not moving two fractures, the bone ends, right? But if I do a pain assessment on that limb and I do it, I'm going to get an out of proportion or disproportionate pain response to a limb that's already injured. So you really need to take all that into consideration too. And it's going to change based on the patient and how they're positioned and their injury distribution. So this is not something to where it's easy to memorize this, but if you put it in context like this, it'll probably stick in your head a little bit more. And I really like this breakdown of where those injuries and how they're assessed and where they fall in the brainstem and the cortex of the brain. That link is a longer video. I think it's a total of like 28 minutes. A lot of good information, but this is a summary from that talk. That's from the ICU Advantage. So I found that to be very helpful throughout the years. And I think it connects a lot of dots and closes a lot of gaps in people's understanding of doing the Glasgow Coma Scale. Anybody have any questions or comments on this? Anything I could clarify or a situation that you'd like to talk through? Alfredo.
Yes, I've got something to say, not about Glasgow Coma Scale, is a couple of slides back about how to treat a TBI.
Okay.
So if we go, I think that's the one. If you go to a remote area, right, when we need to stay with the patient for a long period of time, and if you have epidural, extradural hemorrhage, how do you want to call it, the ventilation strategy, the hypertonic solution, or even mannitol that was replaced by hypertonic, is only going to give us some time. So if the skull is intact, the ICP is going to rise until the patient gets to a place where we start to cone and is going to die in front of us. It looks like a little bit of science fiction and probably got to laugh, but actually there's a few studies already came out that actually we could eventually start thinking about doing craniotomies in remote locations. There's a few articles in Australia that were suggesting critical care paramedics to do it, or advanced paramedics to do it with EZIOs. And actually this procedure has been done for hundreds of years ago with the healers from the tribes to just knock someone's head out and make a fracture, and the pressure will come off. I believe that now I think there's enough studies out there, specifically when we have ICP one of the size, if the pupils start to dilate, we have an idea which hemisphere is affected. I presume this will be something to think about to insert there, because in worst case scenario, we can start treating the patient massively, but the patient is going to die in front of us. He's going to see the eyes going each way, and they're going to cone in front of us, and they're going to die. That's the only one I want to say. Thank you.
Yeah, I agree. This is why TBI head injuries are way up on my list of things that I really don't want to have to treat, because they scare me, because I don't have x-ray vision and my ultrasound won't see through the bone. So there's so much, you can fill the internet with what I don't know about the patient that's got a TBI injury. So I think we had situations where we had surgical teams in Africa, just regular surgical teams without a neurosurgeon. And one of the questions that I asked to neurology and neurosurgery was, how could you easily train a surgical team? That's a whole team of surgeons and anesthesiologists to teach them where to do those craniotomies and drills, burr holes. And you'd have thought that I just took a big dump in the middle of, a wedding or something. It was just, the reaction was significantly emotional for them, that I would even consider someone other than a neurosurgeon drilling into the skull. But I agree with you, Alfredo. I think you need to entertain that discussion about where you would do it. So yeah, I don't have the answer. Obviously, I'm not the decision maker in this, but if I were out in the middle of nowhere, the hardest thing in medicine to do is don't just do something, stand there. And with a head injury, that's basically what they're telling you to do. That's hard.
I put a link into our notes here on a CPG that drops 10 June. So it's less than a month old, or it's over a month old. But emergency life-saving cranial procedures for non-neurosurgeons in deployed setting. And it stated there that burr holes are just not shown enough to this by brain surgeons to do this. Which reminded me, when I was working in Moldova, they had a Makita drill. It was sterilized, they said, and they used that to drill a burr hole. And that, you got to think how big that hole is. This is a neurosurgeon doing this. There's discussions on the IO using an IO for burr hole. It's just not big enough. So look, if a surgeon is not willing to do this, that's just not me.
Well, it's one of those things where you have to understand where the scope of practice is for you. We all have different scopes of practice, and you only get in trouble when you go outside of those scopes and you have a bad outcome. And you still get in trouble when you have a good outcome if you do something, because they consider that a one-off, an exception. So really, yeah. And what would I do in that situation? I'll tell you after it happens. I'd be a fool to admit what I would do beforehand, because I really don't know. I got to be in that situation. So, yeah.
Cool. Well, our hour is up. If you guys have any questions, feel free to email info@corom.edu.mt, and I'll pass it off to either any one of us that can answer that. But next month we missed burns, so we're going to talk about burns and sepsis, other sea circulation things, and we'll slowly work through our PFC algorithm. So thanks for coming, guys, and we'll see you next month.
Thanks, everyone. Great questions, guys. Perfect.
Thanks all.
Thank
Thank you.
Thank you so much.
Thank you all.
Thank you.
Thank you.